Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Liposomal Doxorubicin, Rituximab, Cyclophosphamide, Vincristine, and Prednisone, aka Dr. Kopp, in AIDS-related lymphomas, an AIDS Malignancy Consortium Study 047 by Alexandra M. Levine et al. My name is Dr. Sonali Smith, and I'm an Associate Professor of Medicine in the section of Hematology Oncology at the University of Chicago, Illinois. My oncologic specialty is lymphoma. One of the clearest predisposing etiologies for developing malignant lymphoma is inherited or acquired immunodeficiency, with HIV being the prototypical example. Lymphoma occurring in the setting of advanced HIV was one of the first AIDS-defining illnesses to be recognized. Despite the advent of combination antiretroviral therapy, which has clearly changed the spectrum of lymphoma subtypes, the overall risk of lymphoma in HIV remains 60 to 200-fold higher than non-HIV infected individuals. There is currently no single standard regimen for patients with HIV-associated aggressive lymphomas. Initial studies examined dose intensity in HIV-associated lymphomas with the premise that HIV-positive patients would not tolerate standard doses of chemotherapy. However, many of these trials were done prior to the advent of rituximab, and the focus over the last generation of trials in AIDS-related lymphomas have focused on the inclusion of rituximab, the concurrent versus sequential use of combined antiretroviral therapy, and most recently on the regimens themselves. The concern about using rituximab really was addressing the potential increased risk of infection when specific B-cell depletion was added to multi-agent chemotherapy. An early study by the AIDS Malignancy Consortium and published by Kaplan et al. In Blood 2005 found no survival benefit by adding rituximab to CHOP chemotherapy, primarily due to an increased risk of infectious death in the rituximab arm. However, it is now appreciated that the majority of toxic deaths occurred in patients with CD4 counts below 50 cubic millimeters, and that other patients appeared to have a benefit. Several subsequent studies by the French and by the AIDS Malignancy Consortium confirmed that the addition of rituximab was feasible and that preemptive supportive care could improve the therapeutic index. Most regimens now routinely incorporate rituximab into the management of AIDS-related lymphomas. Similarly, the use of concomitant antiretroviral therapy has been tested, with the main concern being the added risk of infection or toxicity. The National Cancer Institute series of trials systematically excludes current combination antiretroviral therapy in order to avoid interaction with chemotherapy agents, whereas many other national and international groups routinely use combination antiretroviral therapy during primary chemotherapy. The NCI studies have shown that CD4 counts drop and viral loads increase when combination antiretroviral therapy is held, but that this does not negatively impact outcomes. The NCCN guidelines thus reflect that either option is appropriate. Finally, the main question for the current generation of studies in the management of HIV-associated lymphomas is the regimen itself. While improved management of HIV has shifted the spectrum of AIDS-related lymphomas to a more favorable subtypes, there may be some important biological differences between HIV-associated and non-HIV-associated lymphomas, partly due to increased MDR1 expression in the former. Increased MDR1 leads to drug resistance, which may be overcome by infusional chemotherapy regimens. With this rationale, one of the foremost regimens to emerge is EPOCH, which delivers etoposide, doxorubicin, and vincristine on an infusional schedule over 96 hours, in addition to bolus cyclophosphamide and steroids. This regimen was developed at the NCI, and a single institution study showed greater than 70% overall survival rate at 2 years. Our EPOCH was also tested by the AIDS Malignancy Consortium and compared in a pooled analysis against R-CHOP. in this study, published by Sperano and colleagues in Blood 2010, suggested that EPOCH-R had an improved event-free survival with a hazard ratio of 0.4 and overall survival hazard ratio of 0.38. An important observation in this study is that our EPOCH maintained the 70% two-year overall survival seen at the NCI, but this time in a multi-center setting. However, rituximab plus EPOCH has several practical challenges for routine clinical practice. First, it must be delivered infusionally. For some institutions, this requires an inpatient stay. For other places, this requires an infusion pump. Growth factor support is mandatory, and infectious complications are still of concern. Moreover, there is still no prospective Phase 3 randomized trial confirming that one regimen is definitively superior. With this background, Dr. Alexandra Levine and colleagues from the AIDS Malignancy Consortium report the final results of a multi-center prospective Phase 2 trial of Dr. Kopp for 6 to 8 cycles in patients with aggressive B-cell lymphomas. Dr. Kopp includes pegylated doxorubicin, rituximab, cyclophosphamide, vincristine, and prednisone. The intent of the trial was to determine if an outpatient, non-infusional regimen using pegylated doxorubicin could produce results comparable to what was observed with our EPOCH. Growth factor support and concomitant antiretroviral therapy was required in all patients. Patients with a low CD4 count, defined as less than 100 per cubic millimeter, were required to have antimicrobial prophylaxis. Finally, in terms of the treatment program, all responses were assessed by CT scans or MRI, and PET scanning was not part of the protocol. 40 patients are included in the final analysis. Pertinent patient characteristics include a median age of 44 years, primarily men, and 63% of patients being either African American or Hispanic. Most patients had suppressed CD4 counts with a median level of 114 per cubic millimeter and a median viral load of 25,000 copies per ml, all suggesting significant immunosuppression at the time of study entry. We do not know how long patients had HIV in this study or whether they were already on combination antiretroviral agents at the time of lymphoma diagnosis. Other important patient characteristics include a high or high intermediate IPI in 28% of patients, stage 3 or 4 disease in 82%, and 38% of patients having more than one extranodal site. In terms of outcome, the overall response rate was 67.5%, with 47.5% complete responses and 20% partial responses. 1/3 of patients had no response. Importantly, the ability to achieve complete response was not influenced by extranodal disease, low baseline CD4 counts, or high baseline viral load. With a median follow-up time of 25 months, the 1-year overall survival is 70%, and the 2-year overall survival is 62%. The progression-free survival at 1 year is 60.6%. None of the patients achieving a complete response have died, whereas the median survival of PR patients is 9.5 months. However, some PR patients remain alive beyond 2 years, suggesting that metabolic imaging might have shown that these patients were PET negative despite having residual masses. Infection was common, but no patient died of an infectious complication. 2 patients had a grade 4 infection. The main non-infectious toxicity was hand-foot syndrome, leading to patient withdrawal in 2 cases. Importantly, there was an attempt at central pathologic review and an evaluation of cell of origin. 33 of the 40 patients had material available for central pathologic review, which confirmed diffuse large B-cell lymphoma in 23 of the 40 patients. Other histologies included aggressive high-grade lymphoma not otherwise specified, B-cell lymphoma unclassifiable, and Burkitt lymphoma. Among 16 patients where cell of origin could be assessed, 11 had germinal center type. In this subgroup, patients with the germinal center type of diffuse large B-cell lymphoma had a superior 1-year survival of 100% versus only 50% for patients with a non-germinal center type of DLBCL. However, the authors do not clarify how cell of origin was determined, immunohistochemistry or gene expression profiling, and this was only retrospectively assessed. When comparing the results of this study to other recent trials, it is difficult to make a clear statement regarding relative efficacy since this was a single-arm study. However, the overall outcome of a 25-month survival of 62% suggests that this is a reasonable option for patients unable to tolerate R-EPOCH and adds to a list of several existing regimens. Whether or not it is superior to R-CHOP, typically used for non-HIV-associated DLBCL, remains unknown, and we hope the next generation of clinical trials in AIDS-related lymphomas will pursue direct randomized comparisons. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.